If you look at a bridge that's been battered by like decades of harsh weather.
Oh, yeah. Rusting steel,
Yeah.
cracked concrete, the whole bit.
Exactly. And you bring in a structural engineer to look at it, and they're probably going to point at the damage and say, well, it's just getting old.
Right.
Like, we can patch up the cracks, maybe paint over the rust, but we cannot make the bridge young again.
Yeah, because we have this deeply ingrained expectation that biological aging is, much like that bridge. It's a one-way street.
It's inevitable.
Exactly. It's a process of just linear degradation.
Correct.
Tissues break down, they lose their elasticity, they dry out, and we just kind of accept that permanence.
Right. The breakdown is supposed to be final. But what if you could inject something into that bridge and suddenly the concrete started, like literally knitting itself back together?
Which sounds like science fiction.
It does. And the rust reversing itself until you had brand new steel. Because looking through our stack of sources for you today, that is essentially what is happening right now in the world of tissue bioregeneration.
It's wild. It is entirely defying that linear path of aging.
Which brings us to our mission for this deep dive. Today, we are taking you into a highly specific, very cutting-edge area of medicine.
Very cutting edge.
We've pulled together a ton of sources: clinical trials, detailed case reports, complex polymer science studies, and even data on 3D high-frequency ultrasounds.
And we're going to use all of it to answer one incredibly specific question.
Right. The core question.
Sure.
How does the specific molecular weight distribution of sodium hyaluronate, which, you might know as hyaluronic acid or HA, dictate how well it integrates into the tissue of the anterior vaginal wall?
Yeah, and to really grasp the magnitude of this, we kind of have to frame the clinical reality for the listener first.
Let's do it.
Because as women age, particularly as they enter perimenopause and menopause, estrogen levels just precipitously drop.
Right.
And when that happens, the vaginal epithelium undergoes some drastic, often really painful changes.
Yeah, the sources talk about how the tissue physically thins out.
Exactly. It thins out, it loses its natural hydration, and the underlying structural support essentially just collapses, which leads to a very common condition known as vulvovaginal atrophy, or VVA.
And reading through the history here, for decades, hormones were pretty much the only tool we had to treat this, right?
Historically, yes. Systemic or localized estrogen therapy was the absolute gold standard.
You try to coax that atrophied tissue back to health by replacing the missing hormone.
Right, but hormones are not a silver bullet,
No, of course not.
Whether it's a patient with a history of estrogen-sensitive cancers, or someone with a high risk for blood clots, or frankly, just someone who prefers not to take hormones.
There's a massive need for an alternative.
A huge need. And what these sources reveal is that scientists have discovered a completely non-hormonal way to actively regenerate this tissue.
Just by manipulating the physical size of HA molecules.
Yes. It's a profound paradigm shift in how we approach the human body. We are moving away from merely patching over symptoms and entering an era where we can coax the body's own architecture into rebuilding itself.
Okay, so before we get into how HA rebuilds something as delicate and specific as the anterior vaginal wall, we really need to define what molecular weight actually means in this context.
Right, it's crucial.
Because if you've ever looked at a skincare label, you've probably seen hyaluronic acid listed as just a simple hydrating ingredient.
Yeah, a moisturizer.
Exactly. But the polymer science studies in our stack make it incredibly clear that not all HA is created equal.
Oh, far from it. So HA is a glycosaminoglycan.
Oh, wait.
I know, it's a mouthful. Think of it as a very long chain of naturally occurring sugars.
Okay, sugar chains, got it.
And when we talk about its molecular weight, we are literally talking about the physical length of that chain.
Which is measured in a unit called kilodaltons.
Right, exactly, kilodaltons. And broadly speaking, scientists categorize these into high, medium, and low molecular weights. And the length of the chain, it entirely changes how the molecule behaves chemically and physically in the body.
Well, let's start with high molecular weight HA, which the studies define as anything over 1,000 kilodaltons.
The big guys, right?
This forms a massive, dense 3D network. And because it's so physically large, it cannot penetrate deep into the tissue.
Right, it just sits on the surface.
But it can retain up to 1,000 times its own weight in water, which creates this highly protective, hydrating film.
But it doesn't just sit there like a passive wet blanket, This is where the biology gets really fascinating.
Yeah.
Because of its massive size, the high molecular weight HA physically interacts with the surface tissue to suppress pro-inflammatory cytokines.
Okay.
And it actually reduces something called macrophage-mediated phagocytosis.
Wait, hold on. Phagocytosis, that's when cells literally eat other cells, right? Like
Yeah.
the body's immune cleanup crew.
You got it. Macrophages are essentially the body's Pac-Man.
So we are essentially putting this large sugar chain on the surface, and it's telling the cleanup crew to stand down, like stop eating away at the local tissue.
Exactly. In an inflammatory state like VVA, those macrophages can overactively clear out the tissue matrix.
Oh, wow.
Yeah, so the high molecular weight HA acts as a biological shield that calms that local immune response down. It basically tells the tissue, you are safe, you are hydrated, stop attacking yourself.
That's amazing. But then you flip to the other end of the spectrum, low molecular weight HA.
Right, the short chains, under 500 kilodaltons.
And the sources say it does the exact opposite. Because it's a much shorter chain, it doesn't get stuck on the surface.
Now, it's small enough to sink deep down into the mucosal layers.
And once it gets down there, what happens?
Well, it stops acting like a shield and starts acting like a biological messenger.
Okay.
The low molecular weight HA actively seeks out fibroblasts. Those are the specialized cells responsible for manufacturing structural proteins, like collagen and elastin.
Right, the building blocks.
Exactly. It binds to them and essentially forces them to wake up, jumpstart cellular repair, and drive brand new epithelial regeneration.
So if I'm picturing this practically for the listener, it's almost like trying to revive a completely dried out, brittle kitchen sponge.
Oh, that's a great analogy.
Yeah, like if you just put a thick, heavy lotion on the outside, which is your high molecular weight HA, you seal the surface so moisture can't escape. It's your barrier.
Right, but the inside is still completely dry.
Exactly. The center of the sponge is still brittle. You need something like a watery, highly concentrated serum, the low molecular weight HA, that can sink deep into the very center of the sponge to repair the matrix from the inside out.
That is the perfect way to visualize it. You really need both. And the studies reveal an incredible synergy between the two.
They work together.
Yeah.
Right.
When you apply high molecular weight HA to the vaginal mucosa, it acts as that protective surface layer. But the physical weight of that macromolecule network actually pushes the low molecular weight molecules down into the deeper layers.
The weight physically forces them down.
Yeah. The heavy surface layer traps the smaller molecules and physically forces them downward through the tissue matrix to where those dormant fibroblasts are just waiting.
It's literally biological teamwork. But there's also medium molecular weight HA mentioned in these studies, right? Like between 500 and 1,000 kilodaltons.
Yes, and medium molecular weight strikes a very unique balance.
Kind of the best of both worlds.
Sort of, yeah. It provides a bit of that mucosal adherence from the heavy molecules combined with a bit of the tissue penetration of the light molecules.
Okay.
And that specific medium weight is proving incredibly well suited for the unique biomechanics and friction requirements of vaginal applications.
Okay, so we have this biological miracle happening with these different weights. But practically speaking, how does this actually translate to the specific microenvironment of the anterior vaginal wall?
Right, the clinical application.
Yeah, because we are talking about injecting material into the anterior third of the vagina, an area sometimes referred to as the G-spot area. It requires immense precision.
It does, and this is where the concept of true tissue integration becomes absolutely paramount.
How so?
Well, when clinicians inject this HA into the anterior vaginal wall, it does not behave like a traditional cosmetic filler.
Right.
We aren't just plumping up a wrinkle here.
Right.
The HA acts as a bioactive
Well,
scaffold.
scaffold. Okay, looking at the clinical trial data, I see this term CD44 popping up everywhere.
Oh, yes. CD44.
The sources say this scaffolding directly interacts with cell surface receptors, specifically CD44.
Yep.
What exactly is that mechanism doing?
So CD44 is a specific glycoprotein receptor that sits on the surface of many cells, including our friends, the fibroblasts.
Okay.
Think of it as a highly specific lock, and hyaluronic acid is the exact key. When HA binds to that CD44 receptor, it triggers a cascade of intracellular signals.
So it's turning things on.
Exactly. It pulls profound amounts of moisture from the surrounding environment straight into the extracellular matrix, the ECM.
Wow.
And simultaneously, that binding action is what tells the fibroblasts to start producing fresh collagen and elastin.
And they aren't just like guessing that this is happening based on a patient saying, hey, I feel a bit better.
No, not at all.
The diagnostic tools they are using now are wild. Clinicians are utilizing 3D high-frequency vaginal ultrasound, or 3D HFVU.
This changes everything in terms of clinical proof. It really does.
Because before, it was mostly symptom-based.
Historically, yes. Evaluating vaginal atrophy was somewhat subjective, but this 3D high-frequency ultrasound is so sensitive that clinicians can objectively isolate the layers of the vaginal tissue.
That's incredible.
Yeah, they can measure the exact thickness of the anterior vaginal wall completely separately from the posterior wall.
So they can literally watch the tissue rebuild itself on a screen.
Precisely. The ultrasound provides irrefutable visual evidence.
Wow.
When they inject multifractional HA, meaning HA, with a combination of those different molecular weights we talked about, the 3D HFVU shows a direct, measurable thickening effect on the vaginal epithelium over the following weeks.
But wait, I have to ask a skeptical question here, on behalf of the patient listening.
Sure, go ahead.
If I'm the patient looking at that ultrasound screen and I see my anterior vaginal wall getting thicker, how do I know that's actual healthy tissue?
Good question.
Like, is the area just swollen with water? Are we just superficially plumping it like a sponge full of water that's going to eventually just dry out again?
It's a crucial distinction, and the short answer is no. It is not just swelling.
Okay.
The biopsies and functional tests prove this is true physiological bioregeneration.
Mm-hmm.
Because the HA is stimulating that CD44 receptor and driving neocollagenesis, which is the creation of new collagen, it restores complex vaginal functions.
So it's actually acting like younger tissue.
Exactly. The tissue doesn't just look thicker, it acts younger. We see a documented recovery of natural secretion, absorption, elasticity, and lubrication.
That is a total game changer.
It recovers the vaginal tissue at both the superficial epithelial level and the deeper stromal level because it is entirely mimicking the body's own physiological conditions.
So it's a regenerative catalyst, not just a filler, which makes total sense. But if high and low molecular weight HA do completely different things, putting just one single type of HA in a syringe seems like a massive half measure.
It is a half measure. If you only use one tool, you only address one layer of the problem.
Right.
And this realization is exactly what birthed the most advanced treatments detailed in our sources today, which are multi-layer and hybrid injection technologies.
Let's bring in the clinical case report from Clinical Case Reports International.
Yes, the 48-year-old patient.
Right. It follows a 48-year-old perimenopausal woman dealing with severe vulvovaginal atrophy, and the stakes here are very real for her.
Very real.
She had severe dryness, vestibular burning, dyspareunia, which is severe pain during intercourse, basically a total breakdown of function and comfort.
Devastating for her quality of life.
Exactly. And the clinicians decided to use this multi-layer approach.
The architecture of this multi-layer approach is just brilliant. To rebuild her tissue properly, the clinicians used cross-linked HA in the deeper dermal layers and non-cross-linked HA in the superficial layers and the vulvar vestibule.
Okay, let's break that down. What exactly does cross-linking do? Why do we need it deep down?
It's all about longevity. Your body naturally produces an enzyme called hyaluronidase, and its sole job is to break down hyaluronic acid quickly.
Okay.
If you inject regular non-cross-linked HA deep into the tissue, the body's enzymes will dissolve it in a matter of days.
Oh, wow, that fast.
Yeah, very fast. So cross-linking is a chemical process that binds the individual HA chains together into a tighter mesh.
Like a net.
Like a net, exactly.
Huh.
And this mesh resists rapid enzymatic degradation. So the cross-linked HA stays in the deep tissue for months, providing sustained structural action and volumization.
While the non-cross-link stuff is up top.
Right. The non-cross-linked HA at the surface gives acute, immediate hydration and symptom relief.
But reading through this, they didn't just use any cross-linked HA. They specifically use PEGDE cross-linked HA.
Yes.
Why does that specific chemical matter so much?
Because of how the immune system reacts.
Ah.
Sometimes, when you chemically cross-link HA, the body recognizes those new chemical bonds as foreign material.
Which would trigger inflammation.
Exactly, a mild inflammatory response. But PEGD, which stands for polyethylene glycol, diglycidyl ether, is incredibly biocompatible. It essentially acts as a chemical cloaking device.
Wait, a cloaking device? How does a chemical cloak something?
Well, it presents a highly hydrophilic or water-loving surface that immune proteins have a very hard time sticking to.
Oh, I see.
It masks the structural changes introduced by the cross-linking process, so it significantly reduces the immune system's ability to recognize the HA complex as foreign. It dramatically lowers its immunogenicity.
So the body doesn't fight the injection, it just accepts it as its own tissue.
Exactly. This allows for highly biomimetic integration. The body accepts the deep scaffolding with a drastically reduced inflammatory profile, which allows the healing process to happen peacefully.
It's like we're giving the body a perfectly engineered time-release capsule.
That's a great way to put it.
The non-cross-linked HA gives the immediate hydration at the surface, while the PEGDE cross-linked HA is quietly building a long-term architectural foundation deep down, completely undetected by the immune system's radar.
And scientists are taking this concept of synergy even further now.
How so?
The IBSA pharmaceutical data we reviewed details something called Ni-Hi-Co hybrid technology.
Right, I saw that.
Instead of a doctor physically layering two different products during an injection, this technology uses a patented thermal process to chemically stabilize both high and low molecular weights together within the exact same formulation.
Wait, so they're combined in the syringe?
Yes. So
Yeah.
from a single injection point, the tissue receives a synergistic contribution to regeneration. The high and low weights are literally locked together until they reach the tissue.
That is fascinating. Okay, so the molecular weight distribution sets the stage. The cross-linking gives it longevity, it gets the HA to the right depth, and dictates whether it hydrates or repairs.
Right.
But what if we don't want to wait for the body to do this on its own time? Looking at the rest of our sources, there's a whole section on external catalysts.
Yes.
Forcing the issue. Exactly. Clinicians are actively forcing the tissue to integrate the HA faster and stronger.
This is where the deep dive crosses from pure chemistry into bioengineering and physics.
Let's get into it.
Clinicians are now combining the HA with profound biochemical and energy-based adjuncts.
Let's tackle the biochemical side first. The sources talk about combining low molecular weight HA with calcium hydroxyapatite, or KA.
Yes.
That KHA is the main mineral component found in human bones and teeth.
That's correct.
And I have to push back here because injecting bone mineral into the incredibly sensitive tissue of the anterior vaginal wall sounds wildly uncomfortable, if not downright dangerous.
I completely understand why you'd think that.
Does it not just create hard lumps in the tissue?
It's a very natural concern,
Yeah.
but it comes down to the microscopic scale of the delivery. We aren't injecting chunks of bone, you
Right.
know. When formulated for this kind of injection, calcium hydroxyapatite is suspended as perfectly smooth microscopic spheres.
So you can't even feel them.
You cannot feel them at all. But at a cellular level, these tiny spheres act as a rigid physical scaffold.
So they give the cells something to grab onto.
Exactly. The HA is acting as the messenger, screaming at the fibroblasts to grow. But without structure, they just kind of grow aimlessly.
Right, like a vine with no trellis.
Beautiful analogy, yes. The microscopic calcium spheres give those ingrowing fibroblasts a definitive structure to climb on and attach to. It forces the production of highly organized, structurally sound collagen directly at the injection site.
Okay, that makes sense. It's the scaffolding. And then I see the formulations are also loaded with specific amino acids, glycine, L-proline, leucine.
Right, because if you are demanding that the fibroblasts build massive amounts of new collagen, you have to provide them with the raw metabolic material to actually do it.
Right.
Those specific amino acids are the literal fundamental building blocks of the collagen triple helix. Without them, the fibroblasts are just construction workers with no bricks.
So we have the HA acting as the architect giving the orders, the calcium acting as the scaffolding, and the amino acids as the bricks.
Exactly.
But then we introduce physics. The Gavin publishers study details pushing this entire process even further with energy-based adjuncts, specifically dynamic quadrupolar radiofrequency and ultra-pulsed radiooperation.
Radiooperation is an absolute game changer for tissue integration.
Really?
Oh, absolutely. Because you can apply all the architect, scaffolding, and bricks you want to the outside of a cell, but getting it inside the cellular matrix efficiently is a massive biological hurdle.
Because passive diffusion is just too slow.
It is so slow. Radiooperation changes that by applying a very specific rapid electrical impulse directly to the vaginal wall.
Wait, how does an electrical impulse actually get HA into a cell? Does it shock it open?
In a way, yes, but very gently. The electrical field temporarily alters the polarization of the cell membranes.
Okay.
The outer layer of a cell is a lipid bilayer, essentially a barrier of fats. The electrical pulse from the radiooperation physically rearranges those lipids for a fraction of a second, creating temporary aqueous pathways or pores straight through the cell membrane.
It changes the permeability?
Precisely. It literally opens microscopic doors in the cells, allowing these large dipolar HA molecules to instantly enter the deep intercellular spaces much more effectively than they ever could on their own.
And then what happens when the pulse stops?
The moment the electrical pulse stops, the cell membrane seals right back up,
Wow.
safely trapping the HA and the amino acids inside where they can go straight to work.
That is incredible. So if we put this entire complex architecture together for you listening, the specific molecular weight of the HA gets it to the exact right biological depth.
Yes.
The PEG-GEE cross-linking hides it from the immune system. The calcium hydroxyapatite provides the rigid scaffolding. The amino acids deliver the raw bricks. And the radioperation literally opens the front doors of the cells to let the entire construction crew inside.
That is the exact mechanism. You nailed it. And when you connect this incredible science back to the clinical reality for the patient, this synergistic combined approach takes HA from being a mere surface moisturizer to being an active, profound mucosal regenerator.
And the clinical improvements are massive.
Huge.
The numbers in the case reports back that up entirely. Going back to the 48-year-old patient we discussed earlier, they measured her pain on the visual analog scale, the VAS.
Right.
After the multi-layer treatment, her scores for vaginal dryness, burning, and vulvar pain just plunged. I mean, many symptoms dropped all the way to a 0.
It's life-changing.
Yeah.
And arguably more importantly for her quality of life, her female sexual function index, the FSFI6 score, completely skyrocketed.
What were the numbers on that?
Well, a score of 19 or below indicates severe female sexual dysfunction. She started at a 6.
Wow, a 6?
Yeah. After a 6-week follow-up of this combined HA therapy, her score jumped to a 24.
That's incredible.
It is a clinically meaningful, total resolution of her dysfunction.
Which brings us back to where we started. For you listening, the key takeaway from our deep dive into these sources today is that biological aging does not have to be a one-way street.
It really doesn't.
The specific molecular weight of sodium hyaluronate is a hidden biological instruction manual. High molecular weight acts as the shield, protecting and hydrating the surface, telling the immune system to calm down.
Exactly.
While low molecular weight acts as the messenger, penetrating deep to jumpstart cellular repair.
And when you utilize them together, manipulating that molecular weight distribution to achieve true tissue integration in the anterior vaginal wall.
Right.
And you supercharge it with cross-linked stealth scaffolding, calcium, amino acids, and energy-based therapies like radioperation.
You can completely regenerate aging, atrophied tissue.
Yes, and you can do it with a naturally occurring sugar molecule, entirely without the need for systemic hormones.
We've basically gone from patching the cracks on the crumbling bridge to completely rebuilding it from the molecular level up.
We really have, which leaves us with a rather profound implication for you to consider.
What's that?
If we can achieve this level of targeted physiological tissue regeneration in the complex, delicate microenvironment of the anterior vaginal wall, simply by manipulating the molecular weight distribution of a naturally occurring sugar molecule,
Yeah.
what other degenerating tissues in the human body are just waiting for us to discover their exact molecular weight code to reverse the aging process?